and welcome. You're watching Health and Wellness, Myths versus Facts. I'm Gargi Rawat, and today we're talking about pre-diabetes. Now, diabetes awareness and prevention is always a hot topic of discussion among us, but what about pre-diabetes? Now, a good understanding of pre-diabetes is essential for our overall health. As pre-diabetes cases continue to rise in India and around the world, promoting awareness about it is essential. Pre-diabetes doesn't have any clear symptoms, so it often goes unnoticed and undiagnosed. Some people may not realize that they are someone or that someone that they care for could have pre-diabetes. However, early diagnosis and treatment can help prevent or delay serious complications, and raising awareness regarding this and stressing the importance of people knowing their risk is critical, particularly now as the COVID pandemic amplified the negative health risks associated with chronic health conditions. Today we have with us eminent endocrinologists who can help us understand and manage pre-diabetes better. We're joined by Dr. Nikhil Tandon, Professor and Head Department of Endocrinology and Metabolism, AIIMS, New Delhi. We have Dr. Subhankar Chaudhary, Professor and Head of Department of Endocrinology, SSKM Hospital, Kolkata, and Dr. Nihal Thomas, Professor of Endocrinology, Christian Medical College, Vellore. Thank you so much, doctors, for joining us to talk about this very important issue and something that can help people remain healthy and, prevent them from developing full-blown diabetes. Now, Dr. Tandon, I'd like to start with you. Pre-diabetes is a health condition that can progress to type 2 diabetes. So how close is pre-diabetes to type 2 diabetes, and does the transition to full-blown diabetes happen quickly, or does it take a long time?
Thanks for the question, Gargi. So let me just put one slight caveat in this discussion. There's an alternative term which sometimes medical professionals use, and we call it, instead of calling it pre-diabetes, we've also referred to this situation as intermediate hyperglycemia. The reason I say that is that when you say pre-diabetes, there is a connotation of inevitability that people with pre-diabetes will always and immediately transition to diabetes. Fortunately, that need not necessarily be the case. So let me just put that statement out in the open first. The second thing is that the sort of conversion rates from pre-diabetes to diabetes will vary. If you look at a general population, if you take people with pre-diabetes, anywhere between 1% and 5% will transition to diabetes in a year. If you take people who have many more risk factors, who along with their pre-diabetes have significant overweight, who have other metabolic problems, that transition may be as high as 15, even 20% in a year. So it happens. It need not be accelerated. It may not be immediate, but it's there. And I think I'll just also go back before I sort of stop answering this question to something which you raised about using pre-diabetes not only to treat itself, but also to use it as a marker for future progression, and therefore for identifying something to prevent diabetes. And for that, we really need to understand that for prevention of any disease, and here now I'm talking of prevention of diabetes, for prevention of any disease, you really need to have 3 or 4 questions answered. Firstly, is that disease important in terms of its public burden? It is. Do we know the natural history of the early development of that disease? For diabetes, we know. Is there a test by which we can identify this halfway house situation as in pre-diabetes? Yes, we can. And are there safe, effective, and reasonably inexpensive ways of preventing this transmission? And we do. And therefore, the importance of pre-diabetes is not only in the treatment of the condition itself, but to use it as a window to prevent progression to diabetes. And to that, I've already referred to the fact that this can be at variable speeds, but it can be incredibly fast in people who have additional metabolic issues. I'll stop here. Thank you.
All right. Thank you for that, Doctor. And Dr. Chaudhary, if you could tell us which segments of the population are at an increased risk of pre-diabetes and type 2 diabetes. Also, after, the COVID pandemic, since we mentioned it earlier, has there been an increase in people developing this condition?
Right. So there are 2 different parts to this question. Answering the second part first, whether there's increase in the prevalence of diabetes after the COVID, or we cannot yet claim that we are out of the COVID era, but maybe the severe COVIDs are happening less, fortunately. The answer actually is equivocal. There have been initial a lot of studies which suggest that there is a significant increase, but now possibly we are getting a more tempered answer that may not be a great increase in the prevalence of diabetes that we see. Now, coming back to the first part of your question, as to which segments of the population are especially at risk, I must say that all of us, just by the fact that we are Indians, Asian Indians, marks us out as being at high risk for diabetes and also for pre-diabetes. However, having said that, there would be subpopulations who are at greater risk. And those would be the ones who are obese or overweight, those who are physically inactive, women who have had a history of diabetes in pregnancy, we call it gestational diabetes. And many a time that happens only in the later half of the pregnancy. And once the pregnancy is over, the diabetes also tends to go away, but doesn't go away forever. They are at high risk of developing long-term diabetes as well. That apart, there are certain newer groups. For example, today we know a large number of young women, ladies, have something called polycystic ovarian disease. They are at high risk of developing prediabetes and diabetes. Then people who have got something called fatty liver. This is also a term that we shall be hearing about more and more in times to come. They are more at risk. And then maybe Gargi, for you and others, those who are doing shift job, frequently doing night shifts and so on, they are somehow also supposed to be at higher risk. The bottom line, however, is all of us are at higher risk, and therefore we should have some sort of screening, as Professor Tandon has already referred to. Some screening policy should be there so that we can identify these individuals early, because they do not come with symptoms as such.
All right, doctor. Well, you worried me and my entire, production crew, because yes, we all work on shifts here at NDTV. But coming to you, Dr. Thomas, can pre-diabetes also cause heart problems?
Thank you, Gargi, for that very appropriate question. So pre-diabetes can be mentioned as an indirect marker of wellness. In some persons, it is a marker of physical fitness and an indicator that relates to the amount of excess body fat. This is true in some people, but not in all. In general, as Dr. Tandon had mentioned, impaired fasting glycemia and impaired glucose tolerance, which are part of the pre-diabetic spectrum, can on a long term be associated with a slightly higher propensity for a person to develop a heart disease over several years, maybe about 2 to 4 decades later. Since it is also associated with an increased cholesterol at the same time and a reduced muscle mass in some. So let's draw an analogy. If uncontrolled diabetes has a greater risk of developing nerve damage, which is neuropathy, retinopathy, which is eye involvement, and nephropathy, which is kidney involvement, then on a long term, pre-diabetes is a predictor in some people of heart disease and a small percentage of strokes, brain attacks. It is a health marker, but not an immediate panic button. So the public should be aware of this and therefore work with various strategies which we'll be talking about as to how to reduce the frequency and reduce the prevalence of pre-diabetes.
All right. Dr. Tandon, now pre-diabetes itself is a condition, but are there different stages of it? And what indications or symptoms should a person be aware of to understand whether his pre-diabetes is either improving or worsening?
So there were basically 2 ways of making a biochemical or a laboratory diagnosis of pre-diabetes. One is to give what is called an oral glucose tolerance test, and we take a fasting sample, give a person some glucose, and then measure the sugars once again. Or you do a test which is called glycosylated hemoglobin, or HbA1c, which gives us an idea of a consolidated or composite control of sugars in the body for the last 3 months. So using, let's say, the oral glucose tolerance test, you can sometimes divide people with prediabetes or intermediate hyperglycemia into two sort of subcategories: those in which there is an elevation of the fasting glucose, more than normal, but not high enough to be diagnosed as diabetes. Or in some people, while the fasting values are all right, once they're given a glucose load, their sugars rise above what is normal. And once again, high, but not as high to meet a diagnostic criteria for diabetes. So the first one is called impaired fasting glucose. The other one is called impaired glucose tolerance. Some people can be one, some people can be other, and some people can actually have both the conditions. And there is some sort of belief or evidence that people who have both elevated, right, impaired fasting glucose and impaired glucose tolerance, may progress a little bit faster to overt diabetes. Now, in terms of symptoms, I think it's important, and I think Dr. Chaudhary also mentioned that this is, type 2 diabetes itself can be asymptomatic. Prediabetes is invariably asymptomatic, and therefore it becomes critical for us to devise methods for screening people so that you can diagnose people even before they manifest with the symptoms of diabetes. And for that, for example, the government of India offers screening to everybody above the age of 30 years in government institutions. So you just come and get your sugars tested. Let me just give you a little sense of the importance of this. If you take, and these are real data, if you take a concept of what is the lifetime risk of somebody developing diabetes, and we've looked at this in metropolitan cities. Supposing you're a 20-year-old man today, your lifetime risk of developing diabetes is about 55%. If you're a woman, it's about 65%. And if, unfortunately, you're overweight or obese, that lifetime risk becomes 85%. So it's a huge, huge risk. I'm not saying that's what the risk is if you're in a village or a smaller city, but that's important enough to emphasize the need for periodic screening so that the disease can be found in this intermediate state and action taken to prevent it from progressing to overt diabetes. Thank you.
Let's talk about detection now. And Dr. Chaudhary, is the HbA1c test enough to detect prediabetes? And do we need to do additional tests like OGTT to confirm a diagnosis of prediabetes?
Right. So we've already had a sense of what is glycosylated hemoglobin, or HbA1c, which gives us an idea of the sort of the average or integrated blood glucose values over the last 2 to 3 months. So in that, and also that this test can be done at any time of the day. You don't need to fast, you don't need to time after a meal, you don't need to take a glucose drink. So any time of the day it can be done, but this test is more special test, not as easy a test to conduct as a glucose test, and it's more costly. Having said that, your specific question, whether this is enough, well, there has been a lot of talk, and actually there's been a lot of studies to suggest that HbA1c level can be influenced by different factors, including possibly your ethnicity. So there are suggestions that if you are, as I am, you are Asian Indian, then maybe even at given level of glucose, the A1C level may read a little bit lower than if you were a white person, a Caucasian. So the A1C cutoff for diagnosis of diabetes itself is stated to be somewhat low in Asian Indians than in others. However, for pre-diabetes, by and large, it has been found that the value that we see here is similar to elsewhere in the world. And those values are an HbA1c value, which is anything between 5.7% to 6.4% is generally taken as pre-diabetes. Whether we need, once we have a diagnosis on an A1C, to also have a glucose tolerance test. Now remember, glucose tolerance test in the past meant first taking one blood sample of fasting, then giving a glucose load and taking blood every half an hour for next two hours. Nowadays, a glucose tolerance test is simpler. It is found that these intermediate values every half an hour, you don't need to check. It's just enough to do a fasting and one after 2 hours. But even that simplified version, whether you need to do, will partly depend upon how abnormal this A1C value is. And then sometimes the person who comes with the test result also wants a second sort of confirmation. So in those instances, maybe we would like to do another test, but for most instances, I think A1C would be enough to give us a diagnosis of prediabetes.
All right. Now, let's talk about, what we can do to correct this condition. And Dr. Thomas, what steps can a person take to work towards reversing prediabetes and ensuring it doesn't, develop into full-blown diabetes? Which lifestyle changes along with medical treatment are advised for this?
Thank you, Gargi. So we know, therefore, that the lack of a healthy lifestyle is the main reason for the exponential increase in the prevalence of prediabetes. So quite simply, reversal of what one has been doing in terms of a less healthy practice and adaptation of a healthier lifestyle is what is really required. One thing is reversing prediabetes and additionally preventing progression to diabetes. But more specifically, firstly, prevention. Good glucose control and avoid excessive weight gain, particularly during and after pregnancy. People with prediabetes and other risk factors like obesity and hypertension and advanced age should seek a medical opinion before exercising, particularly if they have never exercised before. I should speak about exercise itself a little later. A small amount of weight loss means around 5% to 7% of your body weight. Just 5 to 8 kilograms for an 85 kilogram person can do a world of good. Dietary restrictions for prediabetes bear some similarity to that of a diabetic diet, with restrictions in carbohydrates and fat and increasing fiber intake. Regularization of sleep patterns and taking time off to relax turns off the hormones that would worsen prediabetes. What about medications? It is important to recognize that the foundation is lifestyle change and not medications. Having said that, metformin, which is the primary agent for treating diabetes, may help in a subset of people with prediabetes. More so in those with a BMI greater than 30 kilogram per meter squared and those with impaired glucose tolerance approaching the diabetic range. It is the only authorized medication of prediabetes by the American Diabetes Association. There is plenty on the public domain on other research with other medications like pioglitazone, but this can cause weight gain in many. The GLP-1 analogs, both injectable and oral, can cause significant weight loss, and this can indirectly influence prediabetes. But they are not the primary care, and cost factor is an issue. Nor are they officially authorized for the treatment of prediabetes. So that in a nutshell is how you manage prediabetes.
All right. Well, thank you for that. And clearly maintaining a healthy lifestyle is a key for managing, pre-diabetes or your health conditions. We'll slip into a short break, doctor, and come back with more questions for you. Welcome back. We're talking about, you're watching Health and Wellness, and we're talking about pre-diabetes. Well, let's go across to our doctors. And Dr. Tandon, sometimes it has been observed that people get pre-diabetes even after reversal. Can this be prevented, and what should people take care of after the reversal of pre-diabetes?
So, Dr. Nihal Thomas really explained to us in great detail about what is required to actually go back or transition back from a state of prediabetes to a normal glucose tolerance. But you would have realized there's a lot of hard work involved in that. And the moment you take your foot off the accelerator, you will be right slipping back into a worsened state of glucose control. So these are dynamic positions. These are not solid states that if you move from one to the other, you're captured in that state. So while you can, with effort, revert from prediabetes to normalcy, You can also progress from prediabetes to diabetes, and you can also revert back to prediabetes after having achieved normal glucose tolerance. So really, the part of the lifestyle intervention which Dr. Thomas explained is not just to get you to that state of normalcy, but it's also important for you to be maintained in that state. So this is a continuous, sustained process. It obviously means that you as an individual are predisposed to becoming pre-diabetic or diabetic, and therefore you will have to continue working hard to prevent that from happening. So the key message is the lifestyle interventions and diet and physical activity, and if need be medication, need to be continued throughout so that you retain good metabolic health.
All right. Now, Dr. Chaudhary, fruits are generally considered, healthy food by most people, but people with diabetes can't consume all the fruits. What fruits should a person who's pre-diabetic consume, and also, control the quantity of consumption?
Right. So that brings us to a very important issue, the issue of different myths around what's true, what's correct for people with diabetes. I think we should, first of all, dispel this myth that people with diabetes cannot or should not take or eat fruits. They should. Fruits are good. They have vitamins, minerals, fibers, and so on. Now, what's bad about them is possibly they taste sweet. Many of them do. And the fact is, they contain carbohydrates, they contain sugars. Now, these sugars can be of different types and in different amounts. Remember, even someone with diabetes can be allowed to take a sweet as well. And they don't have to sort of cheatily open the fridge at night and maybe take a few sweets from there. They can do it openly, but with the knowledge that these contain calories, these contain sugars, these will tend to increase the glucose levels. So you need to have only limited amounts of them. And of course, you should try and monitor and check how much does the sugar go up after taking whatever, even sugar, even sweets, but also in this context, fruits. Now, there are certain fruits which have more sugars in them, more of glucose in them. And there are other sugars like fructose, which do not directly or immediately increase the sugar level. And there are some fruits which also contain sucrose, the common table sugar that we have. So some of these fruits like mangoes or grapes or custard apple, these should be taken in moderation. Now, what is moderation? Of course, there isn't a specific book definition for everyone, but I feel in one go, possibly, and even in one day, a reasonable amount would be about 100 grams of any fruit should be okay. And here we do not include the dry fruits. We're not talking of dates. We're not talking of raisins. Which is not to say that they can't be taken, but they have even more calories. So we need to be more careful in taking them. So fruits overall, yes, in limited amounts. If you ask for a specific amount, maybe 100 grams in a day.
All right, Doctor. Well, thank you so much for that. And thank you, doctors, for joining us on the program and talking about this very, very important issue. We're completely out of time. Thanks for joining us, and thank you all for watching at home.